backwards. Hold on a second, folks. There we go. Now it's going to go forward. Back one. Can you go back on that? I'm now turning it over because we're entering cost.
I get the dry stuff. I'm the accountant. So please, no snoring and be careful about drooling on your neighbor. I only have about 7 minutes. I have a lot of stuff to cover. You're going to see a lot of pie charts in here, so I'm going to read a lot. I do apologize for that, but I want to try to get through this. And I'll probably have problems with this as well. So as the doctor said, access is certainly one of the issues in the debate, a lot of focus on that. However, the real issue may be cost because it does affect everybody and is partially responsible for some of the uninsured.
You're there.
Okay. So we have about 15% of the population that's uninsured. Estimates are anywhere from 12.5 million to 15 million in the United States. Critical access is not really the problem, but still 15% is a significant problem. Who are these uninsured? Estimates are all over the place. 18 to 20 million, possibly illegal. 7 to 10 million currently are unemployed or between jobs looking for one. 13 to 15 million already qualify. These would be Medicaid and CHIP program folks. In hospitals, we actually hire consultants to come in once a patient arrives that does not have insurance to help find out whether they qualify for Medicaid. So that leaves us about 2 to 5 million people who are core uninsured who truly are the targets in need. Okay, thank you. So what impact does this 15% have on the price or the cost of health care? An uninsured patient will spend about $30 billion of his own money on health insurance, and that's an estimate for 2008. They'll receive another $56 billion worth of uncompensated care. That includes $43 billion in government support, according to Kaiser's Family Foundation. Uncompensated care includes about $18 billion in Medicaid and Medicare payments to hospitals, and $15 billion indigent care and other care coming from states. That leaves about $13 billion to spread across the system. Estimating 172 million people in the system, that's about $75 each on an annual basis for the cost of this uninsured in the current system. But notice on that slide that only 5% of healthcare is actually impacted by price. Next slide. What's driving the cost? During the period of 1955 to 82, healthcare insurance grew significantly. As more patients didn't pay for their services, the economic effects of price were dissolved. Consumers didn't care what the price was. They didn't negotiate for services. This lack of price dissolves the control of the purchaser over this particular purchase. They had no need to look for substitutes or seek competition. Moreover, how do you insure health? I have homeowners insurance, as I'm sure you do. I've had it for 30 years. Let's say we pay $500 a year. After 30 years, that's $15,000. If a tornado comes along and rips my roof off, that $15,000 is a good investment. Well, insurance is for high-cost, low-probability events, and it works by pooling the risk. Please raise your hand if you are not going to get sick and die. How do you insure that? Demand also drives price. We talked about how having insurance kind of dissolves the economic impact that price has on demand. So Rationing, self-rationing doesn't occur. Rationing occurs in everything. The food you buy, the car you drive, the house you live in. If you don't pay for health care, that kind of dissolves the effect. Clinical services, pharmaceuticals, often have no substitutes, can be life savings, and it does seem that we've become somewhat addicted to just taking a pill for whatever ails us. In certain situations, there is no practical way to seek competition. If you're in the emergency room or you're already in the hospital, it's hard to seek competitive bids for that particular service, at least at the time of purchase. Then there's the lifestyle impact. It impacts the health status and creates more demand. Obesity creates hypertension, diabetes, cancers, orthopedic needs. HMOs have tried to change individuals' behavior and haven't really had success. That comes from the individual to change their own behavior. And the lack of rationing that occurs because of that price mechanism not being there certainly increases the problems we have with our end-of-life decisions. And I think you've heard the President talk about this lately. It truly is part of that problem. So if we look at the end of life, there's been estimates that 35 to 47% of costs are consumed during the last 2 years of life regarding health care. Most of this right now is paid out of Medicare. It's part of the adverse selection associated with that government option.